80% of women do not resistance train, which means 20% of women are utilizing the most powerful stimulus they can to maintain muscle and bone.
That's Sheridan Skye, a registered nurse turned women's health coach on a mission to put a barbell in the hands of every woman.
Most people don't know what they're talking about when they say peptides. They put them all in one container, and it's like, what peptide are you talking about? Because
what even is a peptide?
You are the guinea pig. You don't know what you're getting in that vial.
Does Pilates count as resistance training?
Now you're trying to get her in trouble.
At first.
How many days do you think most women should ideally be resistance training per week?
I like to say to my clients, if you've never feared a leg day,
Yeah.
I fear you've never trained to failure. And skinny is back.
It's terrifying.
It's not something I'd reflected on.
That's because you're a man.
Call that privilege.
Yeah, 100%.
You have a problem with medical misogyny in women's healthcare. Women's pain is generally not taken as seriously as men's.
Yeah.
And so women do go undiagnosed for quite a long time. There was once a patient who came in and she was about 75-ish and she had sustained a fall at home. She had two options, basically. She could take a above-the-knee amputation because her vascular disease had progressed so significantly, or she could go down the route of end-of-life care. She wasn't my patient, she was my nan. Medicine can do a lot for us, a lot. It cannot give us muscle and it cannot give us bone. Those were the two things that my grandmother needed in order to have different options. And she didn't have it and we couldn't give it to her. How do we prevent osteoporosis? How do we prevent sarcopenia? How do we prevent falls?
Yeah.
The glaring thing in my face, no matter how much I looked into it, was
Sheridan, it is so nice to have you here. Sheridan, you started your career as a registered nurse, and your mission now is to put a barbell in the hands of every woman. Mm-hmm. Where did that desire come from?
Hitting with the good questions first. So I started as a on-the-floor PT when I was 20. I'm 35 now, so 15 years.
Yeah.
And it was just one of those things that I did because I needed extra money while I was a struggling student eating mee goreng noodles and just trying to get through my Bachelor of Nursing. I've always had a passion for anatomy, physiology. I've always loved medicine in some degree. Now, at the time, medicine was a really long process. I was like, you know what, I'll become a nurse first, see how I like that, and then I'll decide whether or not I wanted to go down the route of doing medicine. And so my PT was just a on-the-side job.
I feel like that was so many of us. As I'm hearing more stories, same for me. I was like, I'll just do it as a side hustle in college.
Yeah, it's not a real job.
Yeah. And yet all of us are like here 20 years later.
Yeah, exactly. And that was exactly me. It's like, it pays the bills. It does what it gets the job done. Yeah. And I kind of stayed in the fitness industry when I had graduated as a nurse and I went into clinical care, but I was doing online coaching. And this was before online coaching was online coaching, 10 years ago now. Yeah. And I kept my foot in the door, but again, it was just a bit of a side hustle. And I was working in intensive care at the time and I was in the Air Force. So I was a nursing officer. That was going to be my career. I dedicated so much to it and I loved it. I loved every bit of it. It was such a blessing to have that experience. But there was once a patient who came in and she was about 75-ish and she had sustained a fall at home. So she, like a lot of women her age, one of the biggest risk factors is falls and we're always trying to think of how do we prevent falls. But she had quite a complicated history. She had osteoporosis, she had sarcopenia, she had vascular disease. And the reason she presented is because of her vascular disease. Okay. And she had two options, basically. She could take a above-the-knee amputation because her vascular disease had progressed so significantly, or she could go down the route of end-of-life care.
Oh my gosh.
Yes, but she was a very independent woman. She lived by herself. She did everything by herself. She was a little pocket rocket. And so for her, she had something that a lot of people don't have. She got to choose how she wanted to die, which sounds morbid and that sounds intense. But so many of us don't get that privilege. We don't get that privilege to choose what we want and to advocate for ourselves that way. So when she was presented with those options, the complication with her vascular disease is because of her arthritis, her osteoporosis and sarcopenia, she couldn't have a prosthetic leg. She would be bound to a wheelchair. And because she didn't have the resources at home, she would have ended up in a long-term care facility. And she chose that she didn't want that. She felt like the quality of her life meant more than the quantity. And so she chose end-of-life care. And she went into what we call palliative care. And a few days later, she passed away. And at that time, it was, I guess, a pivotal moment for me because she wasn't my patient. She was my nan.
Oh.
Yeah. So there was two parts to me. I, as her granddaughter, like, nan, stay around, like, please. Yeah. As a healthcare professional, I understood why she was making the decision that she was. Yep. And it was at that time that I became a bit obsessed with how do we prevent this? Why does this happen to so many women? You know, every ward you work on or every area of healthcare you work in, it's falls prevention. And I never really looked into why. Like, why do we focus so much on falls? But the reason that we focus so much on falls is because over a certain age, if you have a fall, it's most likely because of a hip fracture. Right. And the death rate within 12 months of a hip fracture is very high. It's up to about 30%, depending if it's a man or woman. For the ones who do survive, they're likely to lose their independence, end up in a long-term care facility. So even the ones who are surviving are having a huge, huge shift in their quality of life and how they live the rest of their life. So for me, I was like, well, medicine can do a lot for us, a lot. It cannot give us muscle and it cannot give us bone. Those were the two things that my grandmother needed in order to have different options. And she didn't have it and we couldn't give it to her. So I was obsessed with, okay, well, what do we do? How do we prevent osteoporosis? How do we prevent sarcopenia? How do we prevent falls? Yeah. The glaring thing in my face, no matter how much I looked into it, was resistance training. Yep. resistance training. And if I was on the side of prevention, being a healthcare provider, by the time women were coming to me, it was too late. Yeah. I couldn't give them those things. And what I also learned is that while resistance training is the most powerful stimulus men and women can use to maintain a good quality of life, to maintain a good quantity of life, 80% of women do not resistance train. It's crazy. 80%. Crazy. So when you put it in another way,
it was that high.
Yeah, it's 80%. In Australia, in America, which means 20% of women are utilizing the most powerful stimulus they can to maintain muscle and bone across their lifespan. So for me, my side hustle job of just paying the bills was like, well,
very easily became the main hustle.
Totally. So to wrap up my TED Talk, the reason that I shifted from clinical care to what I do now and where that mission to get a barbell in the hands of all women in every life stage came from was understanding that there's a lot of reasons why women don't engage in resistance training. Yep. One of them is that when we look at research and clinical practice, it takes a really long time for research to make its way into what we do clinically. Sometimes 17 years. It's decades and it takes a really long time. So who is in the middle of the researchers and the healthcare providers? Coaches. Yep. Coaches are the ones seeing women
that's a really empowering perspective. Yeah,
totally. You know,
it's like there's a lot of downsides to the social media. Anyone can have a platform, but that is a huge upside. Yeah. The fact that we can kind of advocate for these things that the research has proven, but we just can't quite get through the door in the medical industry yet.
It's not even necessarily about the research or science communication. We know that resistance training improves outcomes. So we don't need more information to tell us that resistance training improves these outcomes. We need more people uptaking and engaging in resistance training.
What do you feel the barriers are, Sheridan?
For women,
specifically? Why fewer women are not entering into it at a younger age or even, in their 20s or 30s?
It's a good question. And there's been research done on looking at the barriers to exercise specifically for women. So there's a number of layers. One is generalize. If we generalize, women take up the majority of childcare duties when they have children. So there is a time limitation of course. Sometimes there's a resource limitation. Historically, women have not been encouraged to resistance train. You know, when we've thought about exercise and how women benefit from exercise, there has been an underlying belief that women's bodies are fragile. So I don't know if you guys know of the first woman who ran the Boston Marathon with an actual number.
No.
So her name was Catherine Switzer, I believe. I might have got that wrong, but her name was Catherine. And at the time when she was entering the Boston Marathon, only men could run that race. This was not that long ago. I think it could have been in the 50s, but I could be wrong about the date. So when she entered it, she entered under her initials. So they didn't know that she was a biological woman, because the belief then from a medical perspective was that long endurance activity would impact the fertility of women. Their organs would fall out. It would affect their uterus. I'm not making this up.
Fall out is insane.
Yeah. So when she entered and they're like, well, you're a biological woman. There were people actually trying to take her off the course, and there's pictures of her and that moment. And what's really cool is, full circle, she ran the Boston Marathon with a number not too long ago, you know, much older than she was. And what an incredible time where women are just embraced to be like, your organs are not going to fall out. Everything's going to be okay. So traditionally, women just have not been encouraged to resistance train. There's this underlying belief that it'll make you bulky.
Yeah.
It, you know, when we think of the heroin chic movement and the thin movement, there's a lot of different reasons.
And just trending bodies. Like the idea that across generations, women's bodies are now trending as curvy and trending as heroin chic. It's like, why is this a conversation that we are entertaining?
I know. And skinny is back.
Yeah,
Skinny is coming back.
It's terrifying.
Yeah. But to the last point I just want to make to that, Matt, is we also have to consider the social determinants of health as well, which is, I think, a lot of coaches don't understand or maybe don't consider, because we live in this bubble where we're the ones training the 20%. So we start to think that the 20% are the majority of people.
Yeah.
And
when you said that before, I was immediately shocked. I mean, 65% of our member base is female.
Yeah.
Which I think, you know, skews, and obviously because we're in the industry, which skews it even more. But I had no idea it was as low as 20%.
Yep. And that's the thing, because we see the 20%. We think it's normal. We think our lifestyle is normal, and we have so much privilege in just having the knowledge that we have, the access to gyms. You know, some people can't afford them. Some people don't know where to start. There is a lot of confusion in, you know, women should be doing this, they shouldn't be doing that. And it creates this analysis by paralysis, and people don't know where to start. So it's a bit of a layering that's happening.
I think back to, just 8 years ago when I was living in New York City, and like every woman that came to me was like, I don't want to see muscle. I just want to be toned, which we know that's a whole different conversation, but like literally don't want to get bulky. Don't really want to see too much muscular development. Just want to be lean and toned. And that was, like 8 years ago at max. And now I look around the gym and see the vast majority of our members are women lifting heavy weight. And I'm like, yes, we won. But we haven't, because as you said, it's like such a small bit of the population. I guess my question is, obviously online, social media, all of that helps. But like, how else can we, because it almost feels regional in a lot of ways. Like we are in Sydney, which it is a fitness community as a whole. Yeah. But how else do you see us sort of embracing or getting the word out to the larger world? There's
a number of ways that we can do it. So there are public health initiatives that we tend to see from a government perspective where they encourage the uptake of exercise, you know, as simple as, you know, those little kind of outdoor gyms that you see in Bondi and things like that. We have measures from a public health perspective to try and increase the amount of women or people who just generally engage in exercise. We have a fundamental problem within our healthcare system where doctors, midwives, nurses understand the importance of exercise and what it can do for their patients, but they they're not provided the resources, one being time to sit down and talk with their patients about the importance of exercise. I think a lot of the time we blame GP, you know, I went to my GP and they said this and they did that and they just, you know, brushed me off. It's like, that is a problem. That's a huge problem. But the problem isn't that the doctor didn't want to give you the time. The problem is that we don't have the funding behind our healthcare to provide you with more time in those appointments. So any kind of good healthcare is going to provide a multidisciplinary approach. I can't do everything. You can't do everything. A doctor can't do everything. We're supposed to have this group of people
ecosystem.
who provide that support to patients. So there's no referral to generally physiotherapists or coaches. There's none of that. So one, if doctors had maybe more time, more education, if there was more funding to get people in group fitness programs or whatever it is, that would be great. From a coach perspective, I think one of the things with social media is that we have more information than we've ever had, but that creates a lot of confusion because you see the women should do 5x5, women should not fast, women should cycle sync their workouts, women should do this, no, don't do that. So it's like if you take every little bit at face value, one person's telling you never to eat vegetables, another person's telling you to always eat vegetables, this person, and it's like
insanity.
You're like, you get whiplash just dealing with it. So it's people get overwhelmed and there's an incredible creator. Her name's Dr. Jessica Nurek. If you don't follow her, I really recommend that you do. She's a great public health advocate. And she said this quote on a podcast. I share it on every podcast. So guys, if you've listened to any other of my podcasts, I'm going to just keep sharing this. But her quote is, when you get a problem right but a solution wrong, your solutions either become harmful or not helpful at all. So why I'm sharing that with you guys is, if we pretend that the reason that women have higher rates of fractures, because they do, you know, up to 70% of fractures will occur in women. That's a very high proportion compared to that of men. The reason that that's happening isn't because they're not eating their protein within 30 minutes of a workout, or they're not doing 5x5, or they're fasting, or they're doing high intensity workout instead of zone 2. It's because 80% of them are not resistance training. That is the problem. So if we pretend the solution is something that doesn't fix the problem, then we don't really fix the problem.
Totally.
Do you feel that the initiatives to promote exercise in young females have been in disciplines that were not necessarily resistance training? Is
it? Yeah. Pilates. Yeah. Cardio.
Aerobics.
Yes.
Good old
the Jane Fondas and the, yes.
Is there an age where it's too young to resistance training as a female?
No. So there's a common misunderstanding or a myth around resistance training that it stunts your growth. When you look at the body of research, it just simply does not do that. And I'm not necessarily saying that women as young as possible should just take up resistance training. We need many elements to our health and fitness to be well-rounded, healthy individuals. Resistance training focuses on the stimulus that keeps our muscle and our bone. Doesn't really help it does help our heart health, but if we're really looking at improving cardiovascular fitness, we need to train the stimulus that provides that. We need to do cardiovascular training, whether that's zone 2, 3, 4, whatever. It doesn't really matter at the end of the day. But if we're looking purely from a bone and muscle perspective, I encourage even young girls to take up some form of resistance training. That doesn't mean become a bodybuilder, but you need to be lifting some kind of load effort that stimulates the muscle, that helps that. Because when we look at bone specifically, we will grow the majority of our bone mass up until the age of 30. So as women start to go through puberty, they start to increase their bone mass, and it peaks generally at the age of 30. After the age of 30, we are either maintaining or losing that bone mass. That becomes a bit more of a problem for women because we start with a lower baseline of bone because we, like males, we don't have that high level of testosterone that helps us throughout puberty. So men will start with a higher baseline. biological men, also don't experience perimenopause or menopause. And while menopause is not the cause of muscle loss throughout the biological woman's life, it certainly contributes toward bone loss. So when you start with a lower threshold and then you experience a life phase that biological men do not, you just get closer to the threshold of osteoporosis and that higher risk of fracture before men.
Yeah, much sooner.
Yeah. And what's interesting is, when we look at the death rates between women with fractures and men with fractures, more men actually die of fractures compared to women. Huh. But it's because their fractures generally happen at an older age where there's more comorbidities.
Okay.
Because it just takes longer for them to get toward that threshold. So to answer your question, Matt, as soon as possible, if we're building the majority of our bone mass in that period of puberty and our early 20s, we don't want to be spending that chronically dieting and in a state of low energy availability or, with REDS or hypothalamic amenorrhea. So as soon as possible, really.
That training that's done at 16 and 26 is preparing that woman for 56 and 66. And it's usually only getting addressed once, you're getting towards those problem zones. So it's interesting what you just said then, spending that period in a calorie deficit. Mm-hmm. So you have all this additional pressure to address. I'm not sure if it was just before the podcast started or afterwards, we were saying about the body image sort of cycling round. And if that's then competing on top of these additional methods of training that are sort of perceived as, less resistance or more woman focused, then it's kind of a cocktail for them to never really accumulate what they need in that, most formative period.
Yes. Yeah, I agree. And that's not to say that being in a calorie deficit will guarantee that you have osteoporosis at a later life. It's contextual. We have to, and this is something that a lot of coaches don't do. They do not screen for low energy availability. They do not screen women who are at risk of relative energy deficient syndrome. They do not screen women for hypothalamic amenorrhea. It's not even a conversation that happens.
Can you talk about those a little bit more? Like, what would it look like to screen for those two things?
So you want to be getting data on menstrual cycle regularities. So you first want to think about the women who are at higher risk of energy, like low energy availability. And the reason that low energy availability becomes a problem is because when we think about fertility, it's a very useful tool for human civilization, but we don't need it to survive. Like we need our brain to survive and our heart to survive. It's where resources are not adequate, the body is going to prioritize things that will keep them alive, and fertility is not one of them, right? So one of the problems with low energy availability is women stop ovulating. And because they stop ovulating, they stop menstruating. The problem with that is that throughout a normal cycle, there are peaks of estrogen. And the estrogen is what is protective of bone, as well as external load and resistance training. But if you have a long period without a period without menstruation, because of low energy availability, you're not building that bone mass, or reaching that peak bone mass because you have a period without that estrogen, right? But there are some women who are at higher risk of that. So women with disordered eating, for example, like obviously women with anorexia, maybe bulimia, but also women who are athletes. Athletes have some of the highest risk factors or rates of low energy availability because the output that they're doing exceeds what they're fueling with, right? So you have to identify who are the women who are likely to be at risk. But I think that I screen all of my clients for them. So asking them about their menstrual cycle, asking them, have you had a history of, not having your period? How long did you not have your period for? Do you have your period now? What is your period? Is it regular? Tell me about it, because it gives you clinical signs. And that doesn't mean that we have to be nurses or doctors, but just recognizing who are the individuals that maybe are that high risk, and maybe I need to refer them to someone because this is out of my scope, right? So it's just, I think, screening for everybody and then determining what you do from there. Because if you get a client who's at risk, she doesn't have her period, and then she's like, I want to lose weight. And you're like, yes, sweet, amazing.
I know how to do that.
Yeah, let's go into a calorie deficit. You're just creating that problem for a much longer period of time. and you didn't even know to have the discussion.
That's such an important insight.
Yeah, absolutely. I feel like it seems so obvious, and yet it is so not talked about in the coaching community. Like that should be screening number one.
Someone's not working with a coach, many people listening won't be. For them to just be paying attention to their own, sort of red flags, what should they be looking out for?
So changes in their menstrual cycle, mostly. That doesn't mean that they have no menstrual cycle, but looking at what, no woman really has a 28-day cycle. We talk about the menstrual cycle like it's 28 days bang on. For some women, that's true. For a lot of women, that's not true. And even the same woman has variations in each cycle that she has. So it's not always bang on this period of time. If we look at the standard definition of what is a normal menstrual cycle, it's anywhere between 21 to 35 days, depending on what research you're leaning on. So if you're a woman and you usually are around that 30-day mark, but suddenly it's 33, and then it's 34, and then it's 36, and then sometimes it's there, sometimes it's not. That is a clinical sign that you may have hypothalamic amenorrhea, and that means that you're not ovulating and therefore you're not menstruating. So that would be a sign to go and see a doctor to see what is happening, or just pay closer attention to your cycle. And this doesn't have to be female bodybuilders, yes, because they get so lean for their competitions, they're at higher risk of that. But a lot of women who are trying to lose weight will also experience that. If we as coaches don't ask about their menstrual cycle, and that doesn't mean we cycle sync their workouts, but we are curious about changes within the menstrual cycle. Oh, okay, maybe that's indicating low energy availability, and then having that discussion with them. If they don't have a period at all, that is amenorrhea. That is please go to your doctor. Please, something needs to change here. But any changes in menstrual cycle length is really important to pay attention to when we're looking at low energy availability.
It feels, and I don't want to say anything daft here, but it feels from clients I've spoken to, female family members, that a regular cycle is actually quite uncommon, or less common than a guy might.
That 28-day mark that you would
be led to believe. Yeah. Where is the line between a regular and something to worry about?
Yeah, so great question. Yeah, we're not going to have that 28-day cycle every single month. But if your cycle was 28 days, around about give or take a few days, and now it's suddenly, 7 days longer. It was 28, now it's 35, or you're seeing that consistent change in how the frequency of your periods, that could be a sign of low energy availability. It may also be a sign of something like PMOS, which people would probably know as PCOS, given the name change recently. So there are a number of other reasons why you may have dysregularities in the frequency of your period that is not relevant to low energy availability. But it's really any change within that given, 3 to 4 day period either side, where it's like, oh, maybe this is something worth exploring. But I would say that most people's periods are regular if they're a healthy individual. It's just not bang on 28 days like we tend to think.
So I was diagnosed with PCOS a couple of years ago, but I've had the symptoms since I was 15 years old, like my entire.
Yeah.
I've never had a super regular period. But I was doing some research in the lead up to this, and I found out that 70% of cases go undiagnosed. And I was like, what is going on? Like, where are we getting this so wrong?
Yeah, great question. So for context, PCOS is polycystic ovarian syndrome. That name was recently changed to PMOS, which is polyendocrine metabolic ovarian syndrome. Now, it's a much needed change because PCOS gave a lot of people the impression that it was a problem with cysts. Women had to have cysts in order to have this condition. Well, one, not all women with PMOS, I'll now refer to it as PMOS, have cysts. But even if they do have cysts, they're not actually cysts, they're follicles.
Yes.
Right? They're
I think that was the confusion for me for so long. I'm like, what do you mean? Like, you're meant to have follicles. Actually, I got a scan many years ago. And the person doing my scan was like, oh, yeah, you have multiple cysts, but also they should be there. And I was like, what? Like, I just walked away more confused as opposed to with clarity.
Yeah, exactly. So that's right. When we think of cysts, we think of it's something that shouldn't be there, a cyst on, I don't know, your knee or whatever it may be. They're not cysts. They are follicles. And why that's important is because every cycle we have follicles. That's the cycle of how we menstruate and how women become pregnant. We need those follicles. But the problem with PMOS is that follicle doesn't mature into the process where that woman can ovulate. Right. So it stops maturing for whatever reason. And also, it's not a gynecological problem. It's actually a whole body problem. It's also a metabolic problem. So one of the hallmark problems with PMOS is insulin resistance and hyperandrogenism, which is elevated levels of, we tend to think of male hormones like testosterone, for example. So some women with PMOS don't have those follicles that aren't maturing. They ovulate, they get their period, but they have insulin resistance. They have hyperandrogenism, right? So it's complicated for a number of reasons. It's always it depends, right? A lot of women, if they're, say, on contraception, they don't have a menstrual cycle. So the bleed that is associated with contraception is not a bleed because ovulation has occurred. It's not a naturally occurring cycle. It's a withdrawal bleed from taking the sugar pills or, not taking the pills. You don't menstruate because you don't ovulate. But if you're taking it, you often miss signs of anovulation or you miss signs that your period comes sometimes and it doesn't come other times, which is why with low energy availability, women who are on contraception, it's harder to pick up because they don't ovulate, right? So the reason that it can be difficult with PMOS is because it also can be a number of other conditions. It's not just, sure, you have cysts on your ovaries, diagnosis, Bob's your uncle. It can represent as a lot of other things, right? So it's like, is it type 2 diabetes? What else is going on? Second is women generally, we have a problem with medical misogyny in women's healthcare. Women's pain is generally not taken as seriously as men's. We are often brushed off that's just your period. That's just what it's like being a woman. Take some Panadol, you'll be fine. Use a heat pack, you're going to be okay. And so women do go undiagnosed for quite a long time. Endometriosis is, from a diagnostic perspective, takes a bit longer than PMOS.
Right.
And it's, we need to do better.
Yeah, 100%.
I know you touched on a few there, but it might be worth just elaborating on what are some of the symptoms that a woman might have normalized that could be, an indication to start that process of looking into it sooner? Yeah.
PMOS is challenging because it's not, and you have a lived experience of this. So if it resonates with you, share. If not, that's okay too. But when we look at endometriosis, not for all women, but for some women can be incredibly painful. There's generally not a high amount of pain associated with PMOS. Women might notice changes in their menstrual cycle. The hyperandrogenism, they might notice more hair growth than just generally speaking, because we think of where men generally have hair, generally women don't have hair there, but not all women experience that either. I'm going to ask you, what prompted you to seek a diagnosis for PMOS?
So my cycles were always irregular or extremely long, especially when I was quite young. Acne. Lots of skin challenges. Those were the two major ones that I was dealing with on a regular basis. And just no matter how, I was a ballet dancer all my life, but I didn't have, thank God, I didn't have disordered eating in a significant way. I was very body image conscious, but I was eating. So that could have been contributing. But yeah, those were the major things. I think something that gets so confusing though with PCOS, PMOS, as we think of it through this insulin resistance, a lot of times it is associated with excess body fat and things like that. But there's a lot of women I know that are quite fit, quite healthy, don't present a lot of the signs, and therefore end up in this situation where they're like, well, what?
Yeah, exactly. So it's challenging because most people aren't going to their doctors for irregular cycles unless they're trying to become pregnant. And now they're like, well, this is a problem because I'm having trouble getting pregnant. Yeah. You had some of the clinical signs of the hyperandrogenism, so acne, for example. If women are really concerned with that, they might go to their doctors. But acne can be common throughout puberty as well. So it's like, is it puberty or is it something else? So to answer your question, Matt, I think anytime a woman is noticing changes within her cycle, how regular her cycle is, that is definitely something that should be explored, not just if you want to have children or not want to have children, but because it's very important to have a regular cycle. If you are experiencing hair, hair in certain areas where women generally don't tend to grow a lot of hair, that could be a prompt for you to go and see someone as well. That's specifically for PMOS. If it's endometriosis, generally speaking, it's going to be pain, not just with menstruation, but with ovulation, just generally speaking. Anytime you notice changes in a cycle is worth exploring.
What are some of the potential impacts of not getting it diagnosed, of kind of just putting up with it?
PMOS or endometriosis?
Start with PMOS.
One of them is the metabolic effects that it has. So the insulin resistance creates an environment where you're at higher risk of heart disease. Women with insulin resistance may have more issues with fertility. So when we think about PMOS, if women are not ovulating, what tends to happen is if you don't ovulate, you can't get pregnant, right? But some people still menstruate even though they're not ovulating, right? So one of the problems with PMOS is if you are going through the cycle, so normally when you start a cycle, at the start of your menstrual cycle, basically you're preparing for pregnancy. So the endometrial lining will thicken to prepare for ovulation, possible pregnancy. If a pregnancy doesn't occur, then hormones will change to ultimately shed the lining of that endometrium that's been prepared for ovulation. But because with PMOS, if women are having anovulatory cycles, their body is preparing for ovulation. They don't ovulate, and because they don't ovulate, they don't get that opposing progesterone to help shed that uterine lining. Why that is a problem is because if you have multiple cycles where you have that anovulation, your endometrial lining starts to build up. And when your endometrial lining starts to build up, it's a risk factor for endometrial cancer, which is why some women who have PMOS, who have anovulatory cycles, will be put on progesterone every few cycles to help shed that endometrium. So increased risk of cancer, increased risk of heart disease, increased risk of metabolic disease. So it's not just a gynecological problem, it's a whole body metabolic problem.
Which I think the name change was so significant for.
Yeah.
I'm curious from what you just said, do all women with endometriosis, do they also have PMOS to a certain degree?
They can.
Okay.
They can. They're two separate conditions though.
Right.
Can a woman have endometriosis and PMOS? Definitely.
Yeah.
PMOS is more associated with less pain with the anovulatory cycles and the insulin resistance, for example. Endometriosis, women generally have regular cycles, but it's an inflammatory condition. So endometriosis is where tissue similar to the endometrium grow outside of the uterus. So it can grow, on your intestines. There's been some small amount of research to show areas in the brain, but mostly around, it's a whole body inflammatory condition. And whenever we're creating a lot of inflammation, that creates a lot of other problems in the body. Infertility can certainly be problematic with endometriosis as well, not necessarily because women aren't ovulating, but that inflammatory environment doesn't create the best environment for a pregnancy to go to gestation. They experience a lot of pain, or can experience a lot of pain. They can experience issues with IBS, with the food that they eat. They tend to take or need more time off of work. They tend to take more sick days because of the pain and symptoms associated with endometriosis. There's actually a bill at the moment. It's not a bill, it's a petition to give women with endometriosis more rights for sick leave and annual leave within their
That's amazing.
Their jobs, because it really does, for some, not all, impact how they can, complete their careers, show up at work. So
I had a dear friend go in for a consult around surgery, and they were like, how are you functioning? Like this, they were literally like, this is one of the worst cases we've ever seen. And they were just like, how do you get on around? You must take multiple days off around your period. And she was like, no, like she's just dealt with it her entire life, regardless, because that's just how we've conditioned women. Get on with it. This is just part of the process.
Yeah. And because of that pain, a lot of women with endometriosis end up with pelvic floor dysfunction because of that constant guarding from the pain. So they might experience more incontinence. They might experience more prolapse symptoms. There's a whole host of things that can just really go on. But it's not a gynecological condition. It's a full body condition.
Right.
We have to remember that. It's tricky because generally when you look at gynecologists and the area of medicine, which is gynecology, it's just like, periods are painful. That hurts. That's normal. Get on with it. Here's some Panadol.
Come back and see me when you want to have a baby, and we'll figure it out with some drugs.
Yeah, exactly. It doesn't matter if you're in pain day to day. It doesn't matter if you've got other symptoms. Just come back when you want to have a baby and you're fulfilling your duty as a woman, right?
What role does resistance training play in these conditions?
So with PMOS, resistance training can be super helpful for blood sugar control. So insulin resistance is one of the potential symptoms of PMOS. When we think about how the body utilizes insulin and shuttles glucose into the cells, we generally need insulin. Insulin resistance is a problem because insulin is increasing within the body, but the cells are not receptive to it. Resistance training and exercise has a pathway where you don't need as much insulin for the glucose to be taken into the cells. Just by virtue of exercising, it brings that glucose into the cell because we need it ultimately for, when we're resistance training, glycogen gets shuttled into the cell. So there's less need for insulin when you are exercising. So it's good to manage blood sugar.
Can we give like a very basic understanding of blood sugar, insulin, how it gets pulled into the cell? I feel like a lot of people, you hear it all the time, but you're like, how does this actually work?
Yeah. So when we eat carbohydrates, and so carbohydrates can be fruits, vegetables, it can be sugar, it can carbohydrates. It all comes into the body as glucose. The body recognizes that blood levels of glucose have increased. Now, over time, it's not good to have high levels of glucose within the blood. They need to be shuttled into the cells. It's very helpful for our brain, for our muscles. But in order to do that, the body recognizes, okay, blood sugar levels have increased. We've got some glucose coming into the blood. Then insulin will be released. Insulin is kind of like a lock and key to say, hey, cool, we've got some glucose into this area. I'm going to unlock the door. It's going to go into the cell. Insulin resistance is essentially you've got the lock, but it doesn't fit the key, or it's not going into the key very well. Type 1 diabetes is different because it's an autoimmune condition where you're not making insulin. So you need external insulin. Insulin resistance type 2 diabetes is a little bit different. So does that answer your question?
That's great. Very helpful.
And do other forms of exercise create that same response in the body?
Yeah, so all exercise is going to be beneficial for insulin resistance, all exercise. Even resistance training is, when we think of the general guidelines for physical activity, it's actually not different between pregnant women, the general population, women with PMOS, women with endometriosis. It's 150 minutes of moderate intensity exercise, of which 2 resistance training sessions are recommended on non-consecutive days. It does not change for these populations with PMOS, pregnancy, whatever. A little bit different for postnatal. The recommendations is by 12 weeks postnatal, we want to be encouraging where possible 120 minutes of moderate intensity exercise. But resistance training and moderate intensity training through cardio, irrespective of the condition you have, is going to be beneficial.
Yeah.
I said before, resistance training trains your muscles and your bones. Cardio trains your cardiovascular fitness, your ability to utilize blood and oxygenate the rest of the body. And so we want to use a combination of both, even though the fitness industry is like, I don't do any cardio and look how lean I am. It's like, well, leanness doesn't always equate to health.
Yeah, exactly. How's your heart doing?
Yeah, exactly.
Does Pilates count as resistance training?
Now you're trying to get her in trouble.
I've had conversations with female members about the benefits of resistance training, and I think Pilates can be a really challenging workout, and there's there's definitely the sensation of muscles working, and I really don't have an opinion. I'd be really interested to see, do you feel that it counts?
At first, yes. So what helps me to distinguish what is going to be a helpful stimulus is, does this exercise meet the principle we're trying to apply? So for example, if we were to say, what is the principle of fat loss? We all tend to know, well, you need to eat less than your body burns, unless you believe in the insulin response of the carbohydrate model. The law of thermodynamics dictates.
Whole other podcast.
Yeah, exactly. It doesn't matter what method you use. So we have principles, calorie deficit, calories in versus calories out. We have methods, keto, carnivore, if it fits your macros, flexible dieting, meal plans, taking pictures of your meals. It doesn't matter. Whatever you use needs to fit the principle. So a client might be like, I'm on a ketogenic diet and I'm not losing any weight. It's like, yeah, because you're eating 3,000 calories of butter. Do you know what I mean? It's like,
I tried keto for a second just because I like to be able to speak from experience.
Yeah.
And I was like, this is awful.
Yeah.
Awful.
Yeah. And most people don't do keto anyway because they have a high protein intake. When we think about ketogenesis, protein has the ability for gluconeogenesis so producing carbohydrates. Anyway, moving on. The principle needs to happen irrespective of the method that you use. So the principle of growing muscle is mechanical tension, not metabolic stress. So Pilates is going to provide a stimulus at first, because anyone who isn't exercising or resistance training is very receptive to any stimulus that is provided because it's a new stimulus. But muscle is a very expensive tissue to build. We know that, right? The body will not grow muscle unless you place demands on it to grow the muscle because it's expensive. We don't want to utilize resources that don't need to be utilized. When we think of the how hard Pilates is, because if you guys got me to do a Pilates session right now and got me to pick up those 2 kilo dumbbells, I'd be like, oh my God. And
100 repetitions later you would.
Exactly. So what most people are feeling is the metabolic stress, not mechanical tension, right? So mechanical tension is, and if we conceptualize it, and there's some nuance to this, but an involuntary slowing of the muscle fibers, not the muscles burning and we stop, not we're isometrically holding that position and it starts to burn and we stop. It's very difficult to apply progressive overload and adequate volume in Pilates to apply the principle of mechanical tension. Does that make sense?
So if I know nothing about strength training, how do I know if I am applying enough mechanical tension versus this is just metabolic stress?
You will see an involuntary slowing of the reps. Okay, so we think about a concentric and eccentric. We need the muscle to be going through a lengthening and shortening.
Yep. So bicep curl as we lift that weight up toward the shoulder, that would be our concentric. And as we lengthen it down, that would be eccentric. Yeah. So we need that.
Can we grow muscle isometrically? Of course we can. But generally we're thinking of the lengthening, the shortening, taking that muscle through its full range of motion. So it's using the full muscle. If I was to say, hey, Matt, I want you to do a 10-second eccentric on a bicep curl, that's not mechanical tension because it's not involuntary, right? You're purposely trying to slowly lower that. Involuntary means you cannot recruit enough muscle fibers to physically lift that load.
Yep.
So you don't need to go to failure, but if you record yourself, and this is why I don't love the discussion around RPE and RIR because most people don't know how to apply it.
It's a skill to understand that in your own body. Yeah.
It's a skill. And that doesn't mean that people aren't training hard enough or not trying hard enough. It's a skill that most people aren't taught at all.
Also takes a fair bit of experience to get a good feel for how many reps you have left in the tank.
Yeah. And it's also priming people to tolerate pain. Because it's uncomfortable. Like the first time you do it, you're like, oh, but you get used to that sensation. And so you're able to, over time, learn what failure truly means. But it has to be that involuntary slowing of the reps.
So there could be some confusion between, feeling like I can't do any more reps because the metabolic stress has reached the point where like it's burning or it's pumping or it's painful to do so versus I can't do another rep because it's involuntary. Correct. How would someone sort of like identify the difference?
Use a variety of rep ranges. So generally speaking, when you think about the movements that are going to cause a lot of metabolic stress, it's going to be those high repetitions over and over again. Not always, but if you think about getting in a leg extension for 20 reps, you're probably going to feel that burning sensation more so than if you're doing 6 to 8 reps. So I really do like to play with a 6 to 8 repetition range or 6 to 10 repetition range because the load's going to be heavy enough that they're not able to do so many reps and they start to feel the sensation of, oh, okay, this was burning. This one I couldn't do any more repetitions. So when you play with a variety of rep ranges, it helps the client or the person to understand what does this feel like versus what does this feel like. I really love to get people in a leg extension and ask them, all right, let's pick a load that will get you to, 8 reps. I want you to pick that load. They'll pick a load and then you say, okay, you're going to do as many repetitions as you can. And the only time you stop is when you physically cannot do another repetition. And then watch how many reps they get. It'll be a lot more than 8.
Yep.
Probably.
And so you have to, while you don't have to train to failure to grow muscle, you do have to experience what training to failure feels like because then you know when you're 2 to 3 reps shy of that. Does that answer your question?
Yeah, just to summarize a new stimulus or a novel stimulus, Pilates can have enough of an impact to see some of these health benefits from challenging the muscle. But over time, when people adapt using, greater levels of resistance, progressively overloading it, using heavier weights and more resistance training becomes necessary.
Correct. Okay. Yes.
You were saying something about recording yourself. And then I think we switched gears, but can you go back to that? Because I think that's helpful for people, like to better understand the slowing.
Yeah. So record yourself.
Yep.
Use an RPE or an RIR scale. So if you're going to use an RPE, rate of perceived exertion, 1 to 10, 10 is can't do any more reps. You want to aim between, 7 to 10 reps in reserve, rate of perceived exertion.
Yep.
If you're using an RIR scale, which I tend to like more than an RPE scale, it's the same thing, but it's the opposite. So if you've got 10 reps left in reserve, super easy, no effort really required. If you're at a 2, it means you're very close to failure. You're 2 reps. So 2 reps in reserve. Do that for any exercise. Record yourself, then go back and watch it. And don't ask, how did it feel? Ask yourself, did I see a slowing of the reps toward the end? And if you don't, you probably could do more. Now, there's context if we're thinking of, strength adaptations. If you're doing a 1 rep max, that's different. But we have strength rep ranges and then we have hypertrophy rep ranges. We have a very broad variety of reps that we can use for hypertrophy. We used to think like the old school 6 to 12, whatever textbook you read, really reps up to 30 can produce hypertrophy outcomes. But if we're talking about a strength adaptation, we are looking at load. So you're looking at, 5 reps below, we're building strength adaptations.
Yeah.
So I like to do that because it gives people an objective ability to be like, how slow did those reps get? Did I notice the grunting? One thing that you will tend to notice or should notice when you're getting in that proximity to failure is people will breath hold. Mm-hmm. So naturally the human body will apply a breath hold to stabilize the spine under load. If you're not getting to that proximity to failure, you won't breath hold. Like if someone's just pumping out their reps with, you're not anywhere close to failure, because you will, once you fatigue, you will have to utilize that breath hold to be able to lift more load.
Yeah, and you won't be thinking about anything else.
Correct.
So often as a coach, you want to know if someone's close to that proximity.
When they stop talking to you.
Yeah. Focus goes in, they're
Yes.
not talking, they're not looking around, they're not paying attention to anything other than their lifting.
Yeah. And the facial expressions. And, I like to say to my clients, if you've never feared a leg day, I fear you've never trained to failure.
So true.
Some of the, especially when you're toward the end of a mesocycle where you're like, I've got to, it's like, this is going to be hard.
Yeah. Like if you never feel that way about your workouts, you're not getting the stimulus that you need.
Yeah. Yeah.
If someone, all they've ever done is Pilates and they're like, okay, I get it. I need to enter this strength training world. Mm-hmm. Where do they start? Like what would you typically program out for them? Mm-hmm. How does that journey go?
Well, it always depends on the client, whether they have injuries, what they have access to. But if we think about conceptually, one, how many days do you have to train, right? If you've got 2 days to train, we're going to try and fit it into 2 days. Again, anyone who is new to resistance training, it's a novel stimulus. They're going to be very receptive to the stimulus. If you are more advanced, there's more nuance with how much volume you need, the frequency, et cetera, et cetera. But someone who's just starting, even starting on 2 days is great.
Yep.
Think about push, pull, hinge, squat, and apply whatever exercise you can do within that movement pattern. So I like to think of things conceptually as movement patterns, not is a deadlift better than a squat? Is a this better than that? Just think about your movement patterns. Apply them over 2 days a week. So don't do all of your push in one day and then all of your pull in another. We do want a frequency of, at least 2 days a week. Do whole body workouts. I really like whole body workouts for 2 days. If you've got 3 days, I really like whole bodies as well. Or you could do upper, lower, whole body, just distribute that frequency a bit more. But it depends on how much time they have and where they're coming from.
How many days do you think most women should ideally be resistance training per week?
What's the goal?
Long-term health.
Long-term health, 2's great.
Yeah.
2's great. If they want to grow muscle, I do think that eventually they're going to need a little bit more. There is that conversation around volume. How much volume? Well, it depends on the effort. It's a nuanced conversation, but it depends on the goal. If it's just for general health, 2 resistance training days is amazing. If your goal is muscle hypertrophy, you're going to have to prioritize more specificity toward that goal. So maybe more time resistance training. Yeah. If you want to gain strength, you have to apply more specificity toward that goal. So it depends on the client.
Do you feel like there's still a stigma around building muscle, like growing muscle?
Yes and no. I think we were doing really well for a while there.
Yes. That's my thoughts.
And I think with the introduction of weight loss medicines, it's certainly changing some of the landscape. In some ways, skinny is back. I'm not saying those medicines are not helpful. GLP agonists are, in my opinion, one of the greatest breakthroughs we've had in medicine in a very long time. Yeah. For the right person, they have a tremendous ability to improve their quality and quantity of life. But like all good things, they can also be abused. They can be used incorrectly for the wrong population. I think just not so much in Australia, but, the US, it's so easy to get them.
Yeah.
It's so easy to get them. And so people get them. And they're not monitored. They're not it's not considered how are they going to retain their muscle mass? How are they going to make sure they're getting enough protein? It needs to be a medicine that's guided by a provider that's able to make sure that the right things are associated with them. But yeah, it'll be interesting how it changes the landscape of body image and what's in trend now, because there's always trends, right?
Unfortunately, I have been hearing a lot about strongly encouraged for medical professionals to microdose them for people who do not have type 2 diabetes, are not clinically obese. What are your thoughts on that?
So is it worth us just elaborating on what a GLP-1
yes, 100%.
is, in case people aren't familiar with it?
So a GLP is, so when we think about satiety signaling, so meaning how full we feel, how hungry we feel, one of the mechanisms is you're influencing your GLP receptors, right? So these are medicines that decrease your appetite. They do other things as well. You know, they can manage blood sugar. They can slow down gastric emptying, so your food just sits in your system for a bit longer. But ultimately, they reduce appetite quite powerfully. There are certain types. So you've got your Wegovy, your semaglutide, your Ozempic. Those are all the same thing. They're going to be targeting a certain receptor. And then you have your tirzepatide, your Mounjaros, same thing. They're targeting more receptors than one. Then you've got other ones that are coming out that are not yet FDA approved that are targeting 3 receptors. And the more receptors you're targeting from the research, you tend to lose greater amounts of weight depending on how many receptors are targeted. But they are a useful tool to reduce appetite, get people in a calorie deficit, and therefore they lose weight. So microdosing is you're using a dose that is not leading to weight loss. So it's not high enough of a dose that you're leading to weight loss, right? We do not have data in these populations to support the use of microdosing for inflammation, to prevent heart disease, to prevent dementia, to prevent all the things that people are talking about. One of the arguments is it may decrease inflammation. I mean, maybe. We do not have data in human individuals to suggest that that is true. And all medicines come with side effects, right? So we have to weigh up what are the risks versus the benefits. Do the benefits outweigh the possible risks? You cannot make an informed decision without understanding those two things. How do you make a decision on benefits when you don't know what the risks are? So we know how these medicines work in a population of people who are overweight or obese. We know that, higher rates of fat mass will increase potentially your risk of heart disease, diabetes, stroke, etc. Therefore, the potential risk of the medicine are likely to be worth it for the amount of weight loss that is achieved, because even a 5% reduction in total weight loss can have incredible effects on your metabolic health. For these individuals, the risks are potentially worth it if they can afford them. We don't have that data in a smaller a population where they don't have excess fat.
Body fat,
So any healthcare provider who is encouraging the use of microdosing is purely doing it off of mechanistic ways of thinking. I don't think that's appropriate to be recommending when we do not have human data. We have to be very mindful that medicines come with side effects and we don't just play with things for the sake of playing with things. Maybe that will change in the future, but right now we
just don't know.
There's a couple of things in there I want to touch on. I think, first of all, I think it's a really interesting connection with the fact that skinny is getting easier, maybe turning the trend back to skinny. It's not something I'd reflected on.
That's because you're a man.
But
we call that privilege.
100%. What's going through my head then is like, can we just touch on peptides for a second? Because I feel like peptides has sort of ridden the back of like GLP-1s have been proven to be beneficial, but now we have just gone, all peptides are great. And really, we don't know too much at this stage. What are your thoughts about the health and fitness industry sort of promoting peptides for all sorts of things?
I'm trying to find a politically correct way to answer this.
No need. Just give it to us.
So can peptides be helpful? Yes. A GLP.
Exhibit
peptide. A. There are some nuances if we want to go into biochemistry and how things pharmacologically work. We've got, peptides, we've got proteins. It depends on how many amino acids are attached to it. But let's just reference them all as peptides for now, right? Most people don't know what they're talking about when they say peptides. They put them all in one container. And it's like, what peptide are you talking about? Because they all...
What even is a peptide? I feel like half the people talking about them don't know.
They don't know, right? We have proteins, we have amino acids, we have peptides. It depends on how big the chain is, etc. So, for example, insulin is more so referred to as a protein because of the length of the amino acids, whereas it depends on the medicine that you're talking about whether or not it's referred to as a peptide. Don't quote me on it, but I'm pretty sure GLP agonists are referred to as peptides because their chains are shorter and therefore they don't quite meet the criteria for a protein. But we have a number of peptides that do a number of different things. It depends on the peptide that we're talking about. So for example, insulin, that's going to be helpful to shuttle glucose into a cell for an individual who maybe doesn't make insulin. They are insulin resistant. So peptides can be very, very effective. A GLP is very, very effective. When we're getting into the fitness industry, we're generally not talking about peptides that are, one, FDA approved, or have a lot of human data behind them, right? So what's super interesting is when GLPs have been around for a really long time, like decades. They've only recently been popularized when, we've realized, actually, one of the side effects of this medicine at a high enough dose is weight loss. Yeah. In order to get people to uptake them, it's like, how do we get over the barrier of people injecting themselves at home with a subcutaneous needle? Because that was scary for a lot of people, people who are diagnosed with type 1 diabetes. It's like, oh my goodness, I have to inject myself multiple times a day. There required a lot of education around that. Anyway, we overcame that and now people are injecting everything. Yeah. So it's like, that's fine. We just inject ourselves all the time. So
that's interesting. I haven't heard about that barrier but it makes a lot of sense.
Yeah. It's more normalized, less stigmatized to inject yourself at home, right? Which is well needed for people who need it. But when we're talking about peptides, it's generally, your BP 157s, it's your MOTS, it's your whatever. There are a few problems with that. One, because the FDA does not approve them, and I want to say this, people will throw it's because they haven't been studied. Well, incorrect. There is research on them. Which one? It depends. A lot of that research is done in rats. I'm not sure if people are aware, but humans aren't rats. Clinical trials in animals are very helpful to confirm mechanisms, to create hypotheses, to generate ideas. They are not designed to tell us what happens in humans because what happens in rats is not always what happens in humans. And we see a lot of that in women's health. We cannot extrapolate what happens in a petri dish or a rat and say this is what's going to happen in humans. So the FDA previously did allow compounded forms of certain peptides. Let's say BP 157, for example. They since do not do that anymore. They do not allow compounded variations of these peptides that are not FDA approved. So people are getting them off of, these websites that say, we're a pharmaceutical company, it looks very legit. And then when you go to the terms and conditions, it says for research purposes only. You are the research. Yeah. You are the exhibit that is the research. Hopefully nothing bad happens. I'm not willing to take that risk. I am not recommending any of my clients to take that risk. If we develop research over time to suggest that one peptide may be worth exploring, totally, I'll change my tune. But, there is so much risk that comes with of obtaining pharmaceuticals because peptides are pharmaceuticals. Yeah. And a lot of people that I see even promoting these peptides, it's like, big pharma wants to take your money. And it's like, if peptides these peptides were working, Big Pharma would be cashing
they would be
in.
on it 100%.
Of course.
That's a very good point.
They would. Of course they would. But then the other thing is like...
Sorry, just on that, I might be incorrect, but with it being a protein or with it being a chain of amino acids, does that mean that it can't be patented? And therefore, peptides, it's hard for Big Pharma to be able to like lock up a particular peptide. That's not correct.
No.
I was listening to someone have that conversation recently. I made a little mental note to see whether that was something that had any legs to it.
If there were merit and there was good quality evidence to show the use in humans, Big Pharma would be able to utilize them. Yes.
For listeners, I suppose there's sort of two, there's areas in health and fitness where there's a lot of conversation around how the research doesn't get into action fast enough. And, people can be quite vocal about that in certain areas. Yeah. But then also that could draw people towards, things like peptides and GLPs where the research isn't quite there and be like, oh yeah, but research takes ages to get into mainstream. So if I jump in now, early adopter, it'll get there eventually. Where's that sort of midpoint for someone to be confident that, there is enough research to pay attention, but it's not one of these things that's going to take ages to get into mainstream, maybe like resistance training benefits did at one point?
So it's a difficult question to answer because, yes, what I spoke about before, it takes a long time for research to get into mainstream clinical recommendations for very, very good reason. You are dealing with humans' lives. If you are giving pharmaceuticals to humans, you have to be very sure that the benefits outweigh the risks. There are plenty of pharmaceuticals, GLPs, for example, that were once a theory and a mechanism that have shown to be extremely safe for human consumption or use or prescription, and therefore we recommend it. Where is the line between maybe this is going to pan out as a good option, so I'm just going to take the risk anyway? Okay, so for example, one of the reasons that women are underrepresented in medical and sports science research is because in the 50s there was a drug called thalidomide. It was given to women of childbearing age, and what they found is that it caused tens of thousands of birth defects in women who were pregnant. Therefore, greater measures were taken to be like, okay, we need to be very careful with who we're giving these drugs to. There are ethics that researchers have to go through, that we have to make sure that we are not putting people's lives at risk, that there is enough evidence to support, hey, we've got these mechanistic theories, we've got these Petri dish studies, we've got rat studies. How about now we move to observational studies? We go to people who are taking these medicines and we ask them, we see whether there were outcomes. There is a process in which we have to undergo to make sure it's ethically being studied. Because when you get pharmaceuticals where we have a mechanism and an idea, like BP157, right? It's like people take it for, their joints, that they're like, oh, it targets the very specific joints. No, it doesn't. It does not target the very specific joints. So if you are creating peptides that are very efficient at, let's say, hypothetically, healing a ligament or a tendon, how do you know that it's not targeting the same receptor for a polyp in your colon that could lead to cancer later? We don't know that. So we have to ethically be mindful of what it is we're studying, what's going to happen when we give it to humans. As coaches, as influencers, as wellness practitioners, we are stepping out of line by giving our discount codes and saying this thing absolutely works because the research just hasn't caught up with it. It's like, I remember 3 patients in my clinical career where they came in and they thought they were buying testosterone off of one of these pharmaceutical companies. It wasn't testosterone. It was a peptide called DNP. They died. They died. They were 20. They were men in their 20s.
Wow.
One of them knew that it was DNP. So DNP is sometimes used in the bodybuilding world because it's a very efficient, let's call it fat burner. It increases your internal body temperature. The thing is that there's a very small threshold between how much you take and that mitochondrial uncoupling that just increases your internal body temperature. Wow. It's very difficult to stop once it starts. So we are playing with fire if we are going to recommend them, and it's extremely dangerous in my view. I'm going to wait for human evidence to show us because I don't want people to die.
Yeah, like there's two different buckets we're dealing with. Like one is just the product itself. Mm-hmm. If these are not FDA approved yet or whatever, what is the regulatory body here?
There's a few. There's like FDA. It depends on if you're looking at food or drugs or there's TGA.
But yeah, if we're getting something off of some sort of black market, like we don't actually know that. We don't even know with supplements if it says, if what's in it is what it says is in it.
Yeah.
So that's problem number one. But then problem number two is like, okay, what are actually those downsides to this thing? We just don't have enough information yet.
And you can't get informed consent when you do that. It's that survivorship bias. It's like, if I cross the highway blindfolded and I survive, am I going to tell you guys to go and maybe just try and cross the highway blindfolded?
Yeah.
We don't make clinical decisions based off of survivorship bias. And I'm pretty sure if your loved one was sitting in an intensive care bed as a healthcare provider, you would not want me being like, oh, hey, like I have this theory, let's try it. Yeah. You would want to make sure that those outcomes have been tested time and time again before it's given. And the problem is that as healthcare providers, we have duties of care, we have scope of practice, we are liable for mistakes that we make. And in wellness, you don't have that. You don't have a governing body questioning your decisions, and therefore you can say whatever you want, and it sounds very convincing when I use big words.
I wonder if that'll ever shift.
What are some of the potential downsides of some of these more popular peptides?
We don't know. we don't know because the human research hasn't been done. So maybe some of them will, show in 10 years' time to potentially be beneficial, and they will be utilized. You could look back and say, haha, I told you. Well, that's a risk. And if you're willing to take the risk, then that's fine. However, if you are a person who is recommending them to others, you are completely negating that there is a cost versus benefit decision that has to be made with all pharmaceuticals. You are not in a position to obtain informed consent. Informed consent can only be obtained when we know the risks versus benefits. And if you don't know those, then you are being coerced into a decision because you don't have the information to make that decision. And the other thing is, because these are not regulated by the FDA, because they are being bought not even from a compounded pharmacy, from a third-party website that you are the guinea pig. You don't know what you're getting in that vial. The odds are in your favor. They are.
Yeah.
But you're taking a risk.
Yeah, that's when I'm injecting something into my body, I feel like that's just not a risk I'm willing to take.
Let's not normalize injecting pharmaceuticals into our body without human clinical outcomes.
Yeah, and knowing exactly what's in them. I would love to just touch on, should we be cycle syncing our workouts?
No.
Great.
Is that enough of a touch?
That's
what
it.
were the
That's
reasons why it did become, I want to say the word popular, but prevalent for a while?
Again, it comes back to that mechanistic way of thinking. So when we look at the menstrual cycle, we have fluctuations in estrogen, we have fluctuations in progesterone, in testosterone, in follicle stimulating hormone, in luteinizing hormone. That allows the menstrual cycle to occur as it does. There was a study done in rats where they removed the ovaries from the rats, and they wanted to essentially, I know, poor rats. They wanted to observe what would happen when you abruptly remove estrogen from the rats, because when you're removing the ovaries, you're abruptly removing estrogen because the ovaries are driving that estrogen rise and fall. What they observed is that when they removed estrogen, the satellite cell pool decreased. So satellite cells are very important for muscle hypertrophy. And then when they introduced estrogen, so they gave exogenous estrogen, so they replaced estrogen, kind of, I wouldn't say similar to menopause hormone therapy, but they provided the rats with estrogen. They saw the satellite cell recover. So the satellite cell increased when they provided estrogen. This is fascinating. It's very interesting. While women are not small men, they are not large rodents either. It's a far stretch to take a rodent study to then extrapolate that and say that it applies to human outcomes. So the idea and the mechanistic way of thinking was, oh, well, estrogen must be anabolic then, right? So if we see at the start of the menstrual cycle, estrogen is going to be low. As we get closer to ovulation, we see a rise in estrogen that stimulates, when we have follicle stimulating hormone, luteinizing hormone, we see ovulation occur. If pregnancy doesn't occur, then the progesterone will increase to essentially help with menstruation toward the end of the period. Now, there's a few problems with this. There are rises and fall. Like there's a rise and fall of estrogen, not the same as removing ovaries.
Yeah, not at all.
Not the same. Even extrapolating that into menopause, we do not remove the ovaries from women and say that's the same as menopause. There is a gradual decrease of estrogen over a period of time. Could it be more interesting for women who are, put into surgical menopause, or they have, they're put into early menopause? I mean, maybe, but these are interesting concepts that we don't go as far as to say, well, these are applicable to women. So the idea came from basically that, okay, well, we have these rise and falls of estrogen throughout the menstrual cycle. That means in the follicular phase toward ovulation, there's a surge in testosterone and there's all these surges of luteinizing hormone, et cetera. You're going to be strongest there, right? Then because estrogen is decreasing toward menstruation, take it easy, do yoga, do this. Now we have the follicular phase and the luteal phase. We can separate that into further phases if we want to, but let's just go follicular, luteal. Follicular, menstruation, preparing for ovulation. The luteal phase is after ovulation, pregnancy hasn't occurred. We're preparing for the next cycle. What is the most powerful stimulus for the retention of bone and building muscle? Resistance training. Yeah, that wasn't a good question, guys.
I was like panicked. I'm like,
I don't know. Matt, yeah, you got it right. Resistance training. Does it make sense if I said to any woman, hey, the most powerful stimulus for you to maintain your longevity, your quality of life is resistance training, but for 50% of your life, I want you to do yoga and Pilates?
Not quite.
Not quite.
Maybe
right?
not our best advice.
Common sense prevails here. When we look at how women experience their menstrual cycle, we cannot assume that all women experience it the same. Women do not experience puberty the same. Women do not experience pregnancy, postpartum the same. They do not experience perimenopause or menopause the same. There is a unique experience of every woman, which is why we don't treat hormones, we treat symptoms. What are the symptoms associated with that experience that woman is having? Is that symptom a potential barrier to her engaging in resistance training? Sometimes the answer to that is yes. And then we offer solutions that could potentially remove that barrier. We don't try and replace the hormones or change the hormones, right? So, for example, some women, especially with endometriosis, experience a lot of pain around ovulation. If I say to her, well, actually, you should be hitting PBs now. Some women like myself, so I have PMDD, the best part of my cycle is when I get my period. That is when I get—
We were talking about this before.
The most relief of my symptoms. The period of time right after ovulation up until my period is hell.
Right.
It's very difficult to manage those symptoms. Day one of my period, okay, I am back. Everything feels great. I didn't burn my life down. This is a good month.
Yeah.
If you tell me that, oh, well, actually, you need to take it easy because, your estrogen is low and everything is low, it just doesn't
Missing
work.
out on some vital days where I feel my best. Yeah.
Exactly. And there's a researcher, so Dr. Lauren Colenso Semple, she helped build the women's health coaching for one playground that we're presenting. And she is a researcher. She was a coach previous to her stepping into research and academia. And she had a mechanistic idea that, hey, maybe because of those changes of hormones throughout the menstrual cycle, maybe there's a way that we're supposed to be controlling for these changes in medical and sports science research. So we spoke about women being underrepresented in medical and sports science research, lots of reasons. But another reason is, well, if women have these fluctuations in hormones and men don't, does that mean that it affects the outcomes that women have in research? So if we wanted to look at how do women gain strength, how do they, grow muscle, how do they adapt to endurance, do those changes need to be controlled for to say that, hey, if a woman's in this part of her cycle, she should be doing this, or do we not need to do that at all? So one of the barriers to women being in medical and sports science research was, do we need to control for the menstrual cycle? And if we do, how?
Yeah, can we?
How do we do it?
Yeah.
That's what Lauren was researching. And her original hypothesis was, there's probably going to have to be some way that we're controlling for these outcomes. It turned out that the outcomes aren't different. The changes in the cycle are not associated with different outcomes. You do not need to control or adapt for the hormones. You do need to control for symptoms. How do we do that with clients? We auto-regulate. How do you feel today? You feel like you could hit a PB? I don't know. How about we just try, see how you go? Some of the days that I've gone into my training session and I've been like, oh my God, this has been the worst sleep of my life. My daughter was up like every 2 hours, PB.
Yeah, interesting.
Our rate of perceived exertion is not always indicative of the performance that we will come up with on the day. In sport, what are we to say to women? Oh, sorry, your competition's during day one of your cycle, going to have to sit that one out. Yeah. Yoga and Pilates. It's just not supported by the evidence.
Well, and then you're dealing with the mental aspect, which is, we know, far more powerful. So if we are putting into women's brains, you're weakest between this day and this day of your period, you're probably not going to be performing at the highest level. You can almost guarantee that's going to mess with you when you step into that competition or under the barbell or whatever it is, far more than what's actually happening physiologically in your body.
Yeah, and we see that in research as well.
Yeah.
So whether you think you can or you can't, you're right.
Yeah.
Will there be women listening to this who have adopted cycle syncing and seen benefits from it? And what do they need to consider?
I'm sure that there are women who have seen benefits from cycle syncing. When we say you do not need to cycle sync your workouts, we are not saying your symptoms are not real. We are not saying your experience is invalid. We're saying that you experience your cycle this way, and you notice certain parts of your cycle where maybe cycle syncing does line up with your symptoms. But that's not the reality for every woman. And this is the problem that I have with things like wearables, Whoop, Garmin's, Oura rings. You don't need permission to know that you feel like shit. You don't need to be like, oh, my sleep score is terrible today, I'm going to not train hard. You don't need to be like, oh man, my sleep score is amazing today, but why do I feel so tired? You are allowed to know how you feel and auto-regulate based off of how you feel on the day. You don't even have to auto-regulate based on how you feel on the day. You might get into your session and be like, man, this feels shit. And then you're like, actually, that was the best session of my life. That was amazing. It's not to say that those symptoms are not real. It's not to say that your experience is not real. I am saying we do not manage hormones. We manage symptoms. Because even in a perfect world, if you look at the research on cycle syncing or all the programs on cycle syncing, it's based off of a 28-day cycle.
Right, which we've already discussed.
Which we've already discussed, right? It's based off of the idea that ovulation happens at a very specific time in the cycle. That's not how cycles work. You can take blood levels from women, you can do ultrasounds from women and try and predict when their ovulation is going to happen. And it's not easy to do. So a lot of these wearables that detect or claim to detect ovulation are going based off of temperature. Temperature can be changed or it fluctuates based on a number of things, not just ovulation. You know, what is the temperature of your room? Are you sick? Are you recovered well? There are just so many variables that we cannot control for. So therefore, it's even difficult to know, am I in my follicular phase? Am I in my luteal phase?
From a nutrition standpoint, are there things that we know should change across the... What about just like more calories in certain phases of our cycle? None of it. Fascinating. I don't ever adjust for that, but I'm just kind of curious.
Are you hungrier?
Yeah.
Do you need permission to know that you're hungry? Or can you just be hungry? What is hunger? How do we define hunger? We have physiological hunger. We have emotional hunger. How do you know which hunger you're feeling? I mean, chocolate feels great when I'm toward my period. Does that mean that I need it from a hunger level? I don't know, but I'm going to eat the chocolate. Yeah. I want the chocolate. We just don't need these external permissions to be hungry, to reduce the weight, to not resistance train, to take a rest day, to change our leg day to our upper body. We don't need these external metrics to tell us that. It's like, oh yes, listen to your body and respect the signals that it gives you, but also ignore them and listen to this.
But I think that's also just human nature, right? Like we're constantly looking for someone else to tell us what is right and wrong, how to interpret what's happening in our own body, because we don't have that like innate self-trust. Like, can we just at our core help women and men better connect and understand their own body? Like that's it at the end of the day.
Going back to the point before, even more difficult than ever because there's so much information that is, divisive now. How can someone, is there a filter, is there a lens that they can look through to sort of not accept everything at face value? And when they do have competing information, what's the process of determining whether it's applicable to them?
It's such a good question, and it's tricky. It's tricky to answer because it used to be really easy to spot the grifters. We think of Liver King. We knew that he was we know he's a character. He's
not natural.
I think. Shocking. Surely he is. It's creatine.
Yeah.
Creatine. Just creatine. We know intrinsically that these are characters. What's difficult now is that the grifting is coming from PhDs. It's coming from medical professionals. It's coming from seemingly credible individuals, and it is preying on the vulnerabilities of people who don't understand research. Research is very difficult to understand. It's difficult for me to understand even now, and I read it all the time, and I've been involved in research, and it's still like, it's tricky. Yeah. So what I would like to say is be very mindful of how people talk about things. So when people talk with absolutes and they don't give nuance or context or say, maybe for this person, maybe in this circumstance, these are the risks, these are the benefits. Going back to peptides, it's like, well, look, the risks are that we don't know. And if you're willing to take that risk, then that's on you. That's your informed decision to make. When they present studies that are mechanistic or in rats and they never present human outcome data,
but they're not saying that. That's the problem. Like generally, it's not phrased that way. Like no one knows if it's in rats or not. We're just taking things at face value. And the reality is the viral clips are not the ones where someone is giving nuance.
Yeah, of course. Yeah.
The stuff that's like circulating the internet in a storm is so polarized. And because it's a PhD, we're like, that's credible.
Yeah, exactly.
It's hard.
But you can click on the study and be like, go to the methods section. You don't have to know how to interpret and read that research, but was it done in humans? Is this an observational study or is it testing outcomes? If you have a select few people that you trust, follow them.
Yeah.
But at the end of the day, if you are resistance training, you are eating adequate calories and protein, and you are sleeping well, then you're probably doing what needs to be
90% of the way there. Yeah.
What's the problem? 80% of women do not resistance train.
Yeah.
It's not because you're not taking peptides or not cycle syncing your workouts or not taking creatine. Let's not step over $100 bills to get to pennies.
Yeah, and all these conversations can just become another barrier to actually starting.
Yes.
and picking up the weights.
Very
Exactly. Yeah, I have to collect more information before I start. Analysis by paralysis.
Okay, I want to get into some pre-postnatal stuff. We're going to have you back to talk about this in detail because you've been teaching this for how long?
Oh, it makes me remember my age. My daughter's nearly 7 before then.
Wow. Yeah. Yeah. And so you actually certify or help women go through the certification process. Women and men?
Yes.
Coaches?
So I wrote the pre and postnatal certification for Australian Institute of Fitness and Clean Health. So coaches can become certified in it.
So good. So according to the WHO, 1 in 6 people will be exposed to infertility across the span of their life.
Mm-hmm.
What do we need to do in like the lead up to wanting to conceive as women? How can we better support our bodies to offset some of that?
Resistance train. It's always helpful to attend your doctor's office to just get a general set of bloods. So just making sure that certain nutrients like vitamin D, iron, taking folic acid, super important 3 months prior to conception. Some people will be very angry at that and they'll throw the MTHFR gene at me, but please take folic acid. And if we are considering the time to conception, so there's generally a recommendation for women and or couples to try for 12 months before seeking fertility assistance.
Yep.
However, if you are 35 or around 35, I would be seeking that support sooner. If you have endometriosis, if you have PMOS, if you have hypothalamic amenorrhea, much, much sooner.
Yeah.
But, I say that because some people will try for 2 months and get concerned that it's not happening.
Yes.
It can take time. Not every couple gets pregnant straight away. And some couples it does take up to 12 months. But if you are of that, 35, you have pre-existing conditions. If you're worried about your partner's fertility, then you're going to both go get checked. Men do offer 50% of the DNA.
Yeah,
this
give
is
us
not
some
just
more,
a woman's.
some more. Like, what role does the male play in this process? Obviously, we know, but
yeah.
Like, what do they need to be doing?
Well, they need to be preparing for the same way women do. Abstaining from alcohol if they're smoking, to cease smoking, to consider their micronutrient intake. So 50% of the DNA comes from the man. It's not like a one-person job. So we talk to women: abstain from alcohol. Stop smoking, make sure that you're supplementing, make sure that you're getting blood levels. The man also provides 50% of the DNA.
Yeah.
So this is a biological man and a biological woman's responsibility. It's not just the biological woman's responsibility.
And guys, stay out of those saunas.
Yes. Yeah. Yes. Yeah. So saunas can impact fertility in men. So it's recommended to cease or decrease sauna use if you are trying to conceive. But that's, if you have weight to lose, it can be helpful, but it's not always. The unfortunate reality is that women and men do have a biological window, a biological clock.
Yeah.
And, the risks do increase over the age of 35 for women, and not always. But if you are, having children later in life, then maybe you don't have 12 months to lose weight to prepare for pregnancy. So you have to make the best decision you can. If you are a woman who is in her mid-30s, she hasn't met her life partner yet, she doesn't know if she wants kids, or she knows that she wants kids, but she doesn't have a partner to do, or she hasn't met her life partner to do that with, then consider egg freezing.
Yeah.
It's such an incredible option that women have today, where we don't have to feel pressured into making a decision because we're 30 and we don't have to freak out. You can freeze your eggs and you can consider IVF down the track, and what an incredible, piece of autonomy that we can use. So I think we need to talk a bit more about egg freezing.
Definitely. Well, yeah, the timelines of a woman's life have expanded so much, but it's like the biological clock has not caught up. I don't know if it ever will. That just expands their options for so much longer. And it's such I wish I'd known younger. Yeah. That
a lot of people, a lot of women do, because all of our follicles are created when our mothers are pregnant with us. We will have all of the available follicles we have when we are growing inside of our mother's uterus. And those follicles over time decrease, the quality of them decrease over time, and that impacts pregnancy outcomes. It impacts whether or not we'll be able to get pregnant. So yeah, it's...
What's like the peak health of our eggs? I mean, obviously when you're an infant, but like at what point do they really start to drop off, or is that just person dependent?
They're always dropping off.
Yeah.
You know, every time you're ovulating, you're releasing a follicle. Not all follicles survive as well. But when we look at the increased risk, it is generally over that 35.
Yeah.
And, you know, it increases as we go over 40. It doesn't mean that women can't get pregnant at that time, but there's just a greater risk ratio. There may be greater complications. So if women are unsure, it's recommended to freeze your eggs before the age of 35, and then you utilize the eggs of the age in which you froze them. If you want to get pregnant at 40, then you can utilize those eggs.
Okay, we will absolutely have you back to talk all things like pre-postnatal training, because we could spend another couple of hours on that. So I just want to make sure we spend a little bit of time touching on perimenopause and menopause, because it is so mainstream in the conversation right now. And I think where a lot of the confusion is lying. What are some of the major myths that you're seeing right now that you would like to just clear the air on? And maybe it's just stuff we don't know enough on yet. Maybe they're not quite myths.
Training myths?
Yep.
Or
training myths. Yep. Let's address that first.
So women need to be lifting heavy to maintain bone. That women need to be lifting heavy to maintain muscle. That women should or shouldn't do zone 2. They shouldn't do HIIT. That women need to jump in order to maintain bone. That's just a mess.
Okay, so let's back up on each of those individual ones. So what do we absolutely know about bone in relation to menopause?
So we absolutely know that menopause impacts peak bone mass. So we tend to see a decline in bone across the menopause transition, and that will impact all women because all women will go through the menopause transition. So what we can do before menopause greatly impacts what will happen at menopause. So we spoke about how women, when they get their peak bone mass, etc. So we want to make sure that where possible, we're preserving that. But there's also, when it comes to osteoporosis, there's a genetic link as well to it. So we can do all of the things right, and we still may be exposed or have osteoporosis. Now, we talk about osteoporosis and fracture risk as if it is one part of preventing falls and decreasing mortality. But when we think of bone mineral density, it is a surrogate marker to falls prevention. So the problem is that if you have a fall and you break your hip, then that immobility over a period of time creates like a whole host of issues. Being sedentary increases a whole host of issues. But when we look at something called a FRAX score, this is really taking into account what is your overall falls risk. Your bone density is a surrogate marker to a potential risk of falls, but then you also have muscle mass. You also have balance. You also have coordination. You also, there's a number of different things. So just because you have low bone mineral density, it doesn't mean that you're destined to break your hip and die within 12 months. We want to try and preserve bone mass where possible. We know that exercise isn't a great tool to, like, you're not really going to increase your bone mass with exercise. Maybe if you're very deconditioned, but beyond a certain point, exercise is a great tool to maintain the bone density that you have and the peak bone mass that you have.
And is that true across the entire lifespan or just, okay.
Yes.
Interesting.
Yes. But you want to make sure that you are resistance training. You want to make sure that, you know, if you require calcium or vitamin D or you need to strength train, it's about applying the principles, not you need to lift heavy for 5x5.
Yeah.
A lot of people will quote the Lift More trial where they say, well, in Lift More, you know, there was jumping and there was heavy 5x5 resistance training. It's like, yeah, compared to home training.
Yeah.
Compared to home training, we cannot draw a causation of that. We cannot say, well, heavy lifting and jumping was better or is better when we compared it to training at home.
Yeah.
What about training in proximity to failure? What about certain rep ranges? How come we didn't separate the jumping with the high load resistance training? What if we just did, moderate resistance training?
Right.
Even so, that's looking at the one surrogate of bone health, which is bone mineral density. What about the overall falls risk? What about women in menopause who experience incontinence and prolapse symptoms, which up to 50% of them are going to experience incontinence at this stage of life? Do we put them under a heavy barbell and have them pee their pants while they are exercising? Do all women pee their pants when they're lifting high loads? No.
Yeah.
Look at the person in front of you and think about, do we put 80-year-old Janet who's not resistance trained a day in her life under a heavy barbell squat? No, common sense. Women don't need to necessarily jump. Like you can train power by lifting weights faster.
Yep.
There are a number of ways that we can apply the principle that we're trying to apply. What is that? We're trying to maintain bone mass. We're trying to maintain muscle mass. We're trying to maintain power. We're trying to maintain strength. Variety of methods that we can use to do that.
So first thing I just want to understand, where can people follow you? Where can they be tuned into all of the cool things that you're doing and the research that you're looking into?
Probably Instagram.
Okay.
I'm most active on Instagram, but I have started a Substack.
Oh, very nice.
I love Substack.
Yeah.
It's so nice. Writing. Like I find with Instagram, it's about how do I get your attention as quickly as possible, which is why, the clickbait does so well. But it lacks... Where is the nuance? People don't have the attention span for it. Whereas Substack, I can write and people who want it will go to it. And so Substack or Instagram.
That's so good. All right. How are you currently raising the bar in your life? So fun to see how
am I
people
currently raising the bar in my life? Accepting that I'm not here to be right. I'm here to get it right. So just
love that.
Being curious, being open, learning, adapting. A lot of the things I believe today will probably be different in 10 years. I just try to be a good
being
mom.
Okay with that. Oh, so good.
When it comes to your daughter, how might you prepare her for going into, teenage life and early womanhood to address as many
She's
of
stressed. How dare you?
I lead from the front. So our children don't listen to what we do. They watch what we do. So I try and remember that how I parent her, how I lead as a woman, how I talk about myself, how I talk about others will also be how she does all of those things. The respect that I demand from relationships and friendships will be the respect that she demands, or both of them. I have two daughters. Both of them will demand in their life. So I just try and lead by showing.
So beautiful.
Well, thank you so much.
Yeah,
for
this
today.
is amazing.
I've
so much gold in
a
there.
lot.
Oh, good.
And I think you're a fantastic advocate for women's health and a fantastic role model.
I hope so. Appreciate it.
Thank you, Sheridan. We will hopefully see you very soon.